Assalamualaikum and good day. I am Dr. Ashraf bin Adib and with me is my colleague Dr. Muaz bin Azhari, gazetting FMS representing PKD Gombak. Today, we will be discussing on erectile dysfunction, a crucial yet often overlooked issue in men's health. We would like to acknowledge Dr. Chang Li Cheng, Dr. Tien Kat Nguyen, and Dr. Chow Po Lee as this module contributor. In this session, we will cover the overview of erectile dysfunction, why it is clinically important, how to screen and diagnose it, treatment options available, and how to monitor progress. Erectile dysfunction is defined as the persistent inability to achieve or maintain a penile erection sufficient for satisfactory sexual performance, lasting at least 3 to 6 months. This isn't about a single bad day, it is a chronic issue. Around 52% of men aged 40 to 70 experience some form of erectile dysfunction. In diabetic men, this figure shoots up to 80 to 90%. So it is not rare, just underreported. Erectile dysfunction can be a red flag for underlying conditions like diabetes, hypertension, coronary artery disease, dyslipidemia, and depression. It also impacts mental health and relationships and reduce quality of life, thus making timely diagnosis of erectile dysfunction essential. Data show high associations of erectile dysfunction with other serious treatable disorders, including hypertension, dyslipidemia, diabetes, and others. Addressing erectile dysfunction can help unearth these conditions earlier. A penile erection isn't just about desire. It is a complex coordination between the brain, blood vessels, nerves, along with an adequate endocrine environment. Nitric oxide plays a key role in relaxing smooth muscle, allowing increased blood flow and trapping it in the corpora cavernosa. Erectile dysfunction can result from any disruption in this system, from psychogenic causes like anxiety and performance fear to physical causes like diabetes, trauma, atherosclerosis, or nerve damage. The key is to approach ED holistically, not just with medication. Erectile dysfunction affects every sphere of quality of life. A 2005 Asian male study showed men with erectile dysfunction had dissatisfaction in all components of quality of life, including family life, work performance, relationship, sexual life, and health. It is more than just sex, it is self-worth. A meta-analysis of over 36,000 men showed erectile dysfunction significantly increased risk of cardiovascular disease, coronary heart disease, stroke, and all-cause mortality. There is a 48% higher risk of cardiovascular disease in men with erectile dysfunction. Stroke risk increased by 35%. In short, erectile dysfunction can be an early warning sign. Treating it may prevent a future heart attack and even death. The causes and risk factors of erectile dysfunction can be divided into two main groups, organic and psychogenic. In terms of organic causes, it can be further divided into 5 categories. Number 1, endocrine. Think testosterone deficiency, diabetes or metabolic syndrome, and hyperthyroidism, followed by other uncommon causes like hyperprolactinemia and hyper or hypocortisolism, such as Cushing's or Addison's disease. Number 2, vascular or arteriogenic. Conditions like hypertension, diabetes, dyslipidemia, and smoking leads to buildup of plaque formation, leading to narrowing of blood vessels and peripheral vascular disease. Number 3, penile disorders, including Peyronie's disease, phimosis, hypospadias or epispadias, which not only affects patient organically, but also psychologically, leading to erectile dysfunction. Number 4, neurogenic causes include stroke, spinal cord injuries, Parkinson's disease, polyneuropathy, and post-urethral or pelvic surgery. Number 5, drugs-induced erectile dysfunction, including use of antihypertension, especially thiazides and beta blockers, use of antidepressants, including SSRIs and tricyclic antidepressants, antipsychotics, antiandrogens such as finasteride and dutasteride, and last but not least, recreational drugs such as heroin, methadone, cocaine, or others. Other organic causes includes penile or pelvic fracture and iatrogenic, including radical prostatectomy and transurethral resection of the prostate, which is an uncommon cause. Psychogenic issues are the silent cause of erectile dysfunction, performance anxiety, loss of physical or emotional attraction to partner, issues with relationship, stress, generalized anxiety, and depression are very important cause of ED. Sadly, many men suffer in silence. Reasons include embarrassment, belief that it is part of normal aging, discomfort talking about erectile dysfunction to doctors, high treatment costs, and general perception that erectile dysfunction is not important. This is where we, as primary care clinicians, can change the narrative. We should actively screen men aged 40 years and above, especially those with diabetes, hypertension, dyslipidemia, ischemic heart disease, history of stroke, and smoker. Even if they don't mention erectile dysfunction, we should ask. In helping us with screening for erectile dysfunction, we can use two validated tools widely available. The first tool is the International Index of Erectile Function 5-item questionnaire, IIEF5 in short. It is a validated 5-question tool to assist us in not only screen but also diagnose erectile dysfunction. The validated Malay version has a high sensitivity and specificity. It is reliable and simple. It is also great for monitoring the severity and treatment efficacy. These are the 5 questions in the IIEF5 that we need to ask the patient for erectile dysfunction screening and further diagnose erectile dysfunction based on the severity. Let us look at how to interpret the scores. A score of 6 to 10 indicates severe erectile dysfunction. A score of 11 to 16 indicates moderate ED. 17 to 25 indicates mild ED, while a score of 26 to 30 suggests that there is no erectile dysfunction. Another assessment tool to help us in screening for erectile dysfunction is the Erection Hardness Score, EHS. It is a rating of erection quality from 1, in which penis is larger but not hard, to 2, penis is hard but not hard enough for penetration, to 3, penis is hard enough for penetration but not completely hard, to 4, in which penis is completely hard and fully rigid. We can use erection hardness score as visual analogy to help both clinicians and patients easily understand the quality of an erection. Score 1, tofu, in which the penis is enlarged but not hard at all. This is classified as severe erectile dysfunction. Penetration is not possible. Score 2, peel banana, in which the penis is somewhat firm but still not hard enough for penetration. This represents moderate erectile dysfunction. Score 3, unpeeled banana, in which the penis is hard enough for penetration but not completely rigid. This is a suboptimal erection and may still affect sexual satisfaction. Score 4, cucumber, in which the penis is fully hard and completely rigid. This is considered normal and optimal erectile function. This scoring system is very patient-friendly, and because it uses everyday objects, it reduces embarrassment and confusion when discussing sensitive topics. It also serves as a useful tool to track treatment progress over time. By combining the IIEF5 with erection hardness score, it will give us a clearer clinical picture of erectile dysfunction severity, thus helps us in guiding the therapy.
With risk factors and severity mapped out, we now shift to the heart of ED evaluation, anchored by three pillars: history, examination, and investigation. The cornerstone of ED evaluation is a thorough history, medical, sexual, and psychological, include past relationships, treatments, and partner involvement where possible. Psychological ED often starts suddenly, triggered by stress or anxiety, with preserved morning erections and partner-specific difficulty. In contrast, biological ED develops gradually, marked by reduced morning erections and underlying issues like diabetes or low testosterone. Both types may coexist, so assess for comorbidities and psychological distress caused by the condition itself. Now let's explore the physical exam in ED evaluation. Focus on the genitourinary, endocrine, vascular and neurological systems. Check blood pressure, heart rate and assess the BMI. Central obesity suggests insulin resistance and low testosterone. Reduced femoral or pedal pulses may indicate atherosclerosis affecting penile blood flow. Examine testicular size and inspect the penis for plaques or fibrosis, a sign of Peyronie's disease. Do not overlook congenital anomalies. Remember, ED may precede cardiovascular disease. Men with ED but no cardiac symptoms will face 2 to 3 times higher risk of future CVD events. Let's move into lab evaluation tailored to each patient's symptoms and risk profile. Key tests include fasting blood glucose, HbA1c, and lipid profile as part of cardiovascular risk screening. Additional labs may be considered on case-to-case basis, especially hormonal assessments like early morning testosterone, PSA, prolactin, and luteinizing hormone. The goal is to uncover and treat modifiable factors that may contribute to erectile dysfunction. Let's consolidate ED evaluation into a practical workflow. Step 1. Take a comprehensive history using tools like the IIEF and identify overlapping conditions, reversible risk factors, and psychosocial influences. Step 2. Perform a focused physical exam. Assess genitalia, prostate, and cardiovascular neurological signs. Remember, ED may signal underlying cardiac disease. Step 3. Order tailored labs, glucose, lipid profile, plus morning testosterone when indicated. Consider LH, prolactin, or PSA based on clinical suspicion. Managing erectile dysfunction begins with a clear diagnosis. Is it truly ED or another issue like low libido or relationship concerns? Next, assess cardiovascular risk. ED may signal underlying vascular disease. Evaluate the patient's fitness for sexual activity. Consider cardiac referral for high-risk cases. Then tailor the treatment. Lifestyle changes are foundational. PDE5 inhibitors remains first line, and mechanical or hormonal options may suit certain patients. Psychosexual support is key when psychological factors are at play. Before initiating ED treatment, we must answer one critical question. Is it safe for this patient to engage in sexual activity? European Association of Urology guidelines categorize the cardiac risk stratification among patients with ED based on the second and third Princeton consensus. Patient is categorized into three groups: low risk, intermediate, and high risk. The characteristics for each risk are detailed in this table. Here is the recommended treatment algorithm for erectile dysfunction. After confirming the diagnosis, assess the patient's exercise tolerance. Can the patient walk a mile in 20 minutes or climb 2 flights of stairs briskly? Then stratify cardiac risk. Low-risk patients can be managed in primary care with treatment options reviewed. Intermediate risk cases need further testing to clarify status. High-risk patients, such as those with unstable angina or recent myocardial infarction, should be referred for cardiac evaluation. ED treatment is deferred until cardiac stability is achieved. Let's shift to treatment strategies for erectile dysfunction. Start with sexual counseling and education. Psychosocial support helps address anxiety, relationship issues, and lifestyle factors. Involving partners can uncover hidden challenges. PDE5 inhibitors remains the pharmacologic cornerstone, recommended unless contraindicated. For select patients, mechanical options like vacuum erection devices or intracavernosal injections may be appropriate, especially when oral therapy isn't effective or suitable. Viagra, perhaps the most recognized name in ED treatment, belongs to the class of phosphodiesterase 5 inhibitors. These agents relax corporal smooth muscle, boost arterial inflow, and restricts venous outflow to support erection. PDE5 do not initiate erections, they rely on psychological and environmental stimulation. Sildenafil was the first of its kind to reach the market. Beyond sildenafil, newer PDE5 inhibitors bring distinct benefits. Let's spotlight what sets each apart to guide treatment choices. Sildenafil is the pioneer, effective but timing and food matter. Vardenafil kicks in slightly quicker with similar duration and fewer dietary issues. Tadalafil stands out for its 36-hour window and daily dosing, easing timing anxiety. Daily tadalafil also benefits BPH and frequent activity. All offer about up to 85% efficacy. Importantly, all are contraindicated with nitrates due to the risk of severe hypotension. Vacuum erection devices offer a non-invasive, drug-free alternative for patients who cannot tolerate oral or injectable treatments. Initial satisfaction rates range widely, but adherence drops over time due to discomfort and convenience issues. Common side effects include pain, bruising, and ejaculatory dysfunction. Avoid in bleeding disorders and severe pyronies. Best suited for older patients or those with comorbidities. Proper training is essential, and combining VED with PDE5 inhibitors can enhance outcome. Vacuum erection devices or VED offer a non-pharmacologic option for managing erectile dysfunction. The system includes a cylinder, pump, and tension ring. Negative pressure from the pump draws blood into the penis while during traps it to sustain an erection. Start by sealing the cylinder against the pubic bone, pump until rigid, and then slide the ring to the base. This mimics vasodilation and restricts venous return. Proper technique is essential to prevent pain or ischemia. Alprostadil or prostaglandin E1 works by directly relaxing the corporal smooth muscle with a rapid onset of action within 5 to 15 minutes. It is effective in around 70% of cases. However, contraindications include hypersensitivity, bleeding disorders, and the risk of priapism. Common side effects are penile pain, priapism, and fibrosis. Injection technique matters for safety and effectiveness. Use appropriate needle size to minimize discomfort and tissue trauma. Insert perpendicularly at a 90-degree angle into the corpora cavernosa, avoiding the midline to prevent damage to the dorsal nerve or the urethra. Incorrect depth or angle increases the risk of hematoma or poor drug delivery. Low-intensity shockwave therapy represents a promising frontier in treating vasculogenic erectile dysfunction. This non-invasive technique uses targeted acoustic waves to stimulate angiogenesis and enhance blood flow, essentially acting as microvascular physical therapy. Clinical data shows variable yet encouraging outcomes with 40 to 80% of patients reporting improvement. Benefits typically appear within 3 months, and although peak effects may fade, some response can last up to 5 years. When all other treatments fall short, penile implants offer a lasting solution reserved for those seeking permanence after failed medical or mechanical therapy. Managing ED follows a stepwise approach. Begin with a comprehensive history and shared decision making. Next, tackle modifiable factors lifestyle, risk reduction, and reversible causes. First-line therapy include PDE5 inhibitors and psychosexual counseling. If needed, escalate to vacuum devices or intracavernosal alprostadil. For vasculogenic ED, consider shockwave therapy with daily tadalafil. Assess treatment outcomes through patient satisfaction and function. If all else fails, penile implants offer a definitive solution for those seeking long-term results. Management must be tailored to each patient's response. For full responder, maintain lifestyle changes and monitor for relapse. If improvement is partial, optimize by adjusting doses, combine therapies, and consider psychological factors. No response, revisit the diagnosis. Look for missed hypogonadism, undiagnosed depression, or gaps in medical history. Sexual counseling is essential in ED management. Psychological barriers like anxiety or strained relationships can undermine even organic cases. Techniques like cognitive restructuring, mindfulness, and couple therapy help reframe belief, ease pressure, and rebuild intimacy step by step.
We would like to acknowledge Dr. Lee Yeo-seong, a consultant family physician and subspecialty trainee in sexual and reproductive health in primary care, who has provided us with the slides presented today. Thank you.